have many of you, I don't know if you've used intraosseous injection. So, this is for me, for some doctors, they use it for everything. I find it, as you can see, it's a bit more involved. If a patient has a big, thick ramus of the mandible or buccal cortex, as you can see in the upper left, that's quite a bit of bone to sort of drill through. So you have to sort of pick and choose. But when I really can't get a patient numb, or they report to me that they've had trouble in the past, I'll go right to the the intraosseous. Now, you see that the location that these pictures from the manufacturer are showing you, these are all coming from the buccal. But what I've learned that's very important to remember and makes this whole process a lot easier is if the patient has lost a third molar or maybe even a second molar, and now you have basically an edentulous area of the ridge, that's a perfect spot to pop through because you typically don't have as thick of an outer covering of the bone, and it's very easy to penetrate. So basically coming in through the ridge and then injecting the solution in. Now, remember, for intraosseous, it's a direct injection and flow of anesthesia into the medullary or cancellous bone, which is highly vascular. So if we used epinephrine in these circumstances, you could give the patient that, really jarring cardiac event. So we always want to recommend and remember to use the mepivacaine. So again, this is that 3% solution without epinephrine, okay?